Welcome to Healthy Bottom Line. I am Dana Hayden, a colorectal surgeon in Madison, Wisconsin. And for this episode, we're going to talk about ostomies. And what is an ostomy? Basically, what an ostomy is when we bring up some part of the intestine to the abdominal wall. Okay. Now, this can be different parts of the intestine. So sometimes it's made from the small intestine, sometimes it's made from the colon. Also, there's another kind of ostomy where the urinary tract is actually connected to the intestine, and this is called urostomy. Now, what can be so confusing is we have tons of different terms for these, and it's really hard to know exactly what we're talking about. So a stoma and an ostomy are really just interchangeable words, okay? And they mean the same thing. So basically, it all means a bag. And now there's different types of ostomies, and one is temporary and one is permanent. Again, one is the small intestine, one can be the colon. And generally what they are used for is to divert basically the stool away from whatever is downstream. And it basically, we're pulling up the intestine to the abdominal wall and placing a bag over it. So why do we create these kind of things? There's a bunch of different reasons why we do this. So generally we like to group these in either temporary versus permanent. So a temporary ostomy is generally when we bring up a loop of the small intestine, like a knuckle. We bring it above the abdominal wall. We don't usually staple anything off. And basically this diverts the stool stream to a bag at the abdominal wall and prevents it from going downstream for some sort of particular reason. When we use these, it usually is related to the case where a patient who has rectal cancer is getting treated with chemotherapy and radiation and then a surgery. And then once we remove part of that patient's rectum, we reconnect things and then we protect it with a temporary ileostomy or temporary bag. Other disease processes also use this similar type of temporary bag, and that could be when we have someone with ulcerative colitis that needed their entire colon and rectum out. And then we take the very end of that small intestine, we fold it together and create a pouch or a J pouch, which eventually functions like a new rectum. And because this is a pretty technically challenging and complex surgery, we like to protect this pouch by not letting poop go through it and bringing up a temporary bag. There's other cases where we also do these temporary bags, and that could be if someone, for example, has acute diverticulitis. We take them to the operating room, take out that patient's sigmoid, and then put them back together. And if the patient's a little bit sick or they didn't undergo a bowel prep, then we will also temporarily divert them to let that new connection have its best chance of healing and really preventing someone from getting sick in case there is a problem healing. Now, other instances of temporary bags are where we may bring up the colon or the small intestine because there's an obstruction downstream. And this can be for an obstructing colon or rectal cancer. And if we want to avoid surgery right away and then get them to chemotherapy up front or radiation, we may do a temporary diversion, allow them to undergo treatment, and then eventually reverse that bag along with that cancer operation. Now, temporary bags, we tend to keep them in place for usually about 3 months plus or minus. And before we do what's usually a much easier second operation to reverse that ostomy, we generally will test that new connection that we made, make sure it heals normally, and then proceed with reversing that ostomy. Now, there's other cases where we may do a diversion or an ostomy. And this could be if someone is having lots of trouble controlling their stools or pooping in their pants. And we have a lot of good treatment options for this that may be medical, they could be pelvic floor physical therapy, but if it doesn't work and the patient is just miserable and they are not leaving their house because of accidents or they're always looking for a bathroom, and sometimes I bring this up as an option where we do a temporary bag, and that basically diverts the stool into a bag at the abdominal wall, and that prevents them from having accidents that they can't control. This has been found to significantly improve people's quality of life, and it's another reason why we do these. Now, there are also permanent ostomies or permanent bags. And this can be due to similar situations I just described. But for example, if a rectal cancer is extremely low, involving the sphincter muscles, and we just cannot do a reconnection, that might be a case where we do a permanent colostomy or a permanent bag. Other situations may also require this, and this can be if someone has severe Crohn's disease that's involving the rectum and the perianal skin, for example, with lots of fistulas or strictures. Sometimes we do remove that part of the rectum all the way down to the skin of the anus and bring up a permanent bag. So those are some other cases where we just may not have a choice to do anything temporarily. Now, how do we do these? So basically, we do these surgeries through usually a minimally invasive approach, meaning laparoscopically. So we use a few little 5 millimeter incisions, and we basically bring up a loop of the either small intestine or the colon to the abdominal wall. Sometimes you don't even need any incisions and can just pull this up. And you want basically to protrude that intestine maybe 1 or 2 centimeters above that abdominal wall, which really allows it to be easily bagged, where we put an appliance on top of it and that stool drains into that bag. Now, there are multiple different types of appliances that people use. One can be a bag that's changed every day. You just pull it off and then replace a new one. And other ones are actually one that sits in place for several days, and then it can drain through a spout in the bottom. We not only do the actual surgery, which is actually quite straightforward. It's not a very challenging operation to do these temporary bags. What's very important is we do our best to create an ostomy that's in a very good position in terms of ease of care. So we have our stoma nurses, who are nurses that specialize in stoma care and wound care, and they'll mark someone's abdomen in the best place that it can be in terms of avoiding any folds in the skin, making sure that the ostomy sits either above or below where someone wears their pants. And we measure this out. We give a ton of preoperative instructions and education to make sure someone's comfortable with this. And then right after surgery, we additionally give tons of education and work with the patients, practically speaking, so they're able to take care of their own bags, change the bags, drain the bags, and do all this and be really comfortable with it before they're discharged home. Now, there are some complications and issues that can arise from ostomies. So we do our best to make them as perfect as we can. However, there are some things that can happen, like leakage from the bag, irritation of the skin. Sometimes the ostomy output can be really loose and you can get dehydrated. Other times you can have prolapse, where the ostomy prolapse is more than the first couple centimeters that we had planned, or it can retract. All these things we do our best to manage at the time of surgery to make sure it's as perfect as we can. But some of these factors and some of these complications that happen after the fact are really uncontrollable. So we just do our best to handle those issues as they come. Most of those things can be handled with medications and conservative management. Rarely does anything require a surgery. So when it comes to talking about ostomies, no one is ever super excited about this, I will say. And sometimes it really just freaks out the patient. So I do my best to talk the patient through exactly what to expect. So much information is provided about what type of ostomy it's going to be, what can be expected, if it's temporary or permanent, and then what exactly we will be planning in terms of the preoperative marking, the post-operative care, and then what to expect in the long term. Now, why people are so freaked out about this is because usually someone has had a family member or knows someone who just had an awful, nightmarish situation with a bad ostomy. Over time, we've come up with amazing innovations to really work with people and make the appliances easy to use, fit every body, and really optimize ostomies for patients. You can really do whatever you want. Once you get through this quite steep learning curve, there's no activities that you can't do with a bag. And especially there's times where these bags aren't necessarily temporary, and I have to talk about creating a permanent colostomy in someone who's quite young. And this sometimes is the focus of the conversation, even though we may be doing the surgery for a pretty severe cancer operation. And again, there's a lot of education that happens before, during, and after surgery. And I think this part of it, once someone kind of climbs that learning curve and gets used to it, suddenly you realize that this is something that you can absolutely live with, you can thrive with, and all those preconceptions and like the stigma that are associated with it definitely fall to the wayside. Other issues, like I spoke about, how we do diversion or create an ostomy when someone is having problems controlling their stools. I will say I bring this up as an option, and once in a while a patient is just at their wit's end and are ready for the colostomy. Sometimes I mention it and it takes several months or even years to get to that decision. But after creating the ostomy, we are absolutely giving patients their life back, where they have more control over their life. They're leaving their house. They're not worried about where the closest bathroom is. And we can significantly improve patients' quality of life. So again, it's a big hurdle to get through, but I've seen patients just thrive after a creation of a colostomy or an ileostomy, and really get patients through what's, of course, an extremely challenging decision. So I will say ileostomy and colostomies, no one's very excited about these things. Sometimes, depending on the disease process, patients we don't have a choice. It is something that is absolutely indicated either from a cancer perspective or for the disease process. If it is temporary, generally we can do a very second easy operation. There are times when someone undergoes an emergency operation and the type of permanent ostomy is actually an end colostomy or an end ileostomy, and those patients may require a much more extensive operation to reverse it, still being temporary, but is more of an impact on that patient's life in terms of delaying the reversal, usually around 6 months, and requiring a much larger operation to reverse it. All that being said, there's plenty of people that you wouldn't even know have an ostomy. How we fit these appliances, they're very flush to the skin, they're very sticky to the skin, so it really allows a good seal. We have tons of different tips and tricks and troubleshooting we do to take care of people's ostomies if they're having a little bit of issue in terms of like leakage or irritation of the skin. And we've come so far in terms of ostomy care that people can really just live their best life and thrive with an ostomy, and you would never know it. Thank you for listening. This is Healthy Bottom Line.